everything is menopause. The kids are driving you up the wall. That's menopause. Everything is theoretically menopause. And the problem is it could be. So it's really hard. Ask for a referral. Come and see us and let us counsel you and walk through all of that and give whatever advice we can.
Welcome to the HSE Talking Health and Wellbeing podcast. My name is Noreen Turley, and today we're focusing on a vital and often misunderstood area. We're not just talking about menopause, but today we're talking about complex menopause. While many people associate menopause with hot flushes or changes in mood, for some women, underlying health conditions or treatment limitations can make it a much more complicated journey. Joining me today is Dr. Caoimhe Hartley, a GP and women's health specialist. Caoimhe is going to help us understand what complex menopause really is, how it's managed and what supports are available to help women navigate this stage of life. So today we're going to talk about understanding complex menopause. And thank you very much for joining us today, Caoimhe.
Lovely to be here. Thank you.
First of all, the word, even complex menopause, what does it mean?
So we define the Complex Menopause Clinic as being a clinic for women who are experiencing symptoms of either perimenopause or menopause or premature ovarian insufficiency, which is early menopause, and who have other medical issues or a background medical history that might make it difficult for them to take hormone replacement therapy. So these are women who often go to their GP and maybe the GP is not sure about how to counsel them in terms of their risk and their benefit of treating their menopausal symptoms using different things like HRT. So if you look at the criteria we have for the complex clinic, it is usually women who have a medical history of something like an estrogen-dependent cancer. So about a third of our patients have actually had breast cancer would be the most common. But there are other hormone-dependent or hormone-sensitive cancers too, like womb cancer, for example, or maybe women with a history of ovarian cancer. And then as part of that, we would also see women who have maybe certain genetic conditions, who carry something like the BRCA gene that women might have heard of, which also increase their risk of things like breast and ovary cancer. It's a bit more complicated in terms of counselling them with regards to HRT. And so they're women who are really appropriately sent to see us. And then other medical conditions like having had a history of maybe a blood clot in your leg or your lung, or a family history of something like that, liver dysfunction. There's a list of different things. So basically, complex medical history, that makes you a bit more tricky and your GP sends you in to see us.
Okay, great. So that's brilliant that GPs can refer on if they have any difficulty with trying to support the woman going through the menopause and they come to you guys. So what happens when they come to you in the Complex Menopause Clinic? Who do they meet? And what are the stages that they go through?
So the background here is we've 6 complex menopause clinics now in the country. So Holles Street was the first in the National Maternity Hospital. The clinical lead there is the fabulous Dr. Deirdre Lundy. And then our clinic in the Rotunda was number 2. So we were the second. So we're open almost 3 years.
Very good, yeah.
And there's also Complex Clinic in Cork, Galway, Limerick and the Coombe.
Very good. So 6 clinics around the country.
And they're based on catchment area. So you can't sort of decide where you're going to go. You go based on your catchment area, depending where you're living and the hospital that is closest to you. So that's the background. And it's GP referral only. You can't self-refer to these clinics. You maybe have a chat with your GP. If the GP thinks, yeah, this is more suitable to be seen in one of these complex clinics, they do a referral, usually through a thing called HealthLink, which is online. It's electronic. And that will be then triaged and seen by a member of our team. And then hopefully an appointment is arranged. The patient is notified of that and in they come. And then they meet one of our teams. And the teams change because it depends who's available and all of that. But at the moment in the clinic in the Rotunda, there's myself. And then I have a fabulous nurse called Mercy Neenan. So she works with me. I have a wonderful physician's associate who's been with me from the beginning, Ruth Murphy. She's absolutely brilliant as well. We usually have another doctor, either a gynecology registrar or GP who is in training. And that sort of makes up our team. And then obviously we've brilliant admin staff behind us too.
Yeah. And so Caoimhe, because I have friends of mine who have had breast cancer and they say, well, oh, I'm having symptoms, but I can't go on HRT. And they just make that assumption and then they think there's nothing for them out there. So I suppose part of this podcast is letting people know that there is something out there for them.
Yeah, and I think if you look back to what happened a few years ago with Joe Duffy and all of that sort of the big sort of shift in attitude, the kind of change in the zeitgeist, whatever you want to call it, of you know, women's health. And all of a sudden there was this explosion of people talking about perimenopause and menopause and the impact of those symptoms, not for everyone, but for people who were experiencing that. And then what their options were and how safe HRT is and why aren't more people on it. And and all these positive stories. Oh my God, my life is so much better. I'm so glad I started HRT. And then there were a whole cohort of women who were getting totally left behind because they either couldn't or chose not to take. They didn't want to go down the route of HRT, or they were told that they couldn't, which might be totally reasonable. But they were left sort of sitting there going, well, like, what about me? Like, what do I do then? And am I going to get osteoporosis and will I die of a heart attack? Because that's all I'm hearing is,
really?
oh my God, it's so important for your heart and so important for your bones. And they got totally sort of left out of this conversation. So it became apparent then that these women were presenting to GPs who are highly skilled, masters of all trade job. Like, general practice is extremely challenging, but they cannot be experts in absolutely everything. And these are women that just by nature of their history were often more complex. So the GPs didn't know how to tackle it either and felt that maybe it was for some GPs beyond their comfort level of expertise. And these women needed somewhere to go, which is where the kind of drive to set up these clinics came from.
Yeah.
So we are only too delighted. Like, it's so rewarding.
It must be. What about the fear, though? The fear of people, oh no, I can't take HRT because I've had breast cancer. And you said, what did you call it? The estrogen fed.
Like a hormone sensitive cancer.
Hormone sensitive cancer.
Yeah.
So will they even go to their GP looking for it? Or do they just think, oh, I just have to put up with this now because I can't take HRT?
So we see sort of two avenues of referral. We see people who have attended their GP, had the conversation, and the GP thinks this is complicated. The counselling about your risk and stuff is really nuanced. Or I know you can't have HRT and I don't know what else to give you. And they refer them on to us, which is grand.
Yeah.
We also see women who are linked in with oncology services. So they're either coming straight from breast clinic or wherever they're linked in with. And it's the consultant oncologist or breast surgeon that will send the patient to us. It's interesting because if you have come through cancer treatment, for a lot of women, the treatment itself plunges them into menopause. So they have chemotherapy, radiotherapy or whatever, or even surgery, whatever it happens to be, depending on their diagnosis. And that itself brings on menopause. They go into a surgical menopause. The analogy that I tend to use is that with natural menopause, because your ovaries sort of wobble a lot before they peter out. They don't just come to an abrupt halt. It's like trying to get into cold water and you're tiptoeing in. And it's still, for a lot of women, really nasty and they get lots of symptoms. It's still hard. But for women who have surgical menopause or medically induced menopause, it is honestly like putting your foot to their back and kicking them off a cliff.
Oh my God.
And they go flying into the cold water and it's this shock to their system, like pulling a rug out underneath them. So they're often more symptomatic on top of everything else, which is a real kick in the teeth. Like, they've just come through cancer treatment and then this. And I suppose some of the medications they use, particularly for women who've had estrogen receptor positive breast cancer, they would go on some medications whose job it is to get rid of your estrogen or block all of your estrogen receptors, which is essentially menopause, but on steroids then. It's making all of the menopausal symptoms worse and more exaggerated. Although important to stress, not for everyone. Because the women who are on these medications or who've had treatment and are feeling well, and they exist, I don't see them because I don't need to.
Is it part of the preoperative chat? I know people have to deal with an awful lot when they're coming in for maybe breast surgery due to cancer or whatever. But should it be something that's just mentioned to them and the information given to them that if the situation arises post, because it could hit you, like you said, like jumping off a cliff into cold water, is that done?
I'm not sure that it is done. It's certainly not done in any formal way. And we would really want to see that be the next step, particularly for younger women, but really for all women who have a diagnosis of something where it is quite predictable that this is going to impact their hormone production in some way, either through, as I say, surgery or treatment or the medication they're given afterwards. And even if they end up being women who do not go on to develop symptoms, well then great.
Yeah.
But what's the downside with linking them in with us early?
Absolutely.
And the amount of women I meet who have put up with symptoms after having their cancer treatment. And the attitude often from oncology, and it's the right attitude from oncology, is, well, I've dealt with the cancer part of this because I can't treat their cancer. I can't do that. Oncology do their bit, but are not maybe equipped either with the time or the resources or sometimes the knowledge to deal with the other issues that arise.
Yeah, and I can completely get that. But if it was just something that was even mentioned or something within that system that could be signposting if you do need help afterwards.
But like, why not even link them in with us? We meet them once. We do a quick 15-20 minute consultation. They get to know us. We get to know them. There's development of some sort of rapport. And then they go off thinking, okay, now I'm going to go have my treatment now. Don't know what lies on the other side of it. I may never need that clinic again.
Yeah.
But I know they are there if I do. And sure, I've met them and they're so nice.
Yeah.
And that one is lovely.
It's just joined up thinking, really, isn't it? Your service is quite new, and I'm sure you have all these ideas and plans for the future. So I don't want to preempt any of those.
But you're trying to change how things have been done for a really long time. And that's really hard. And again, I can kind of understand from the oncology perspective how anticipating symptoms that might never happen aren't a priority when you're just trying to deal with the acute issue. But we would say, look, for the sake of 20 minutes, flag it. I think it's really helpful.
Yeah.
And I think it would alleviate people's anxiety, what might be coming down the line, to know that we've loads of options.
Yes.
We've loads of options. You don't have to have symptoms that are destroying your life.
This is the thing. So at one stage, we'd no information about the menopause. Now, everybody's a menopause expert. Every friend, everybody you meet at your book club. It's just unbelievable. There's information out there everywhere. There's all these influencers who are advertising all of these different weird and wonderful combinations. And some of it is really, really good. It's just mind-boggling. And even in preparation for doing this podcast and updating myself, it's scary, really, what's out there. And how do we spot it? What do we say to people?
Yeah, it's really overwhelming, isn't it, for women? And I think having the entire internet at your fingertips is both a positive and sometimes a really negative thing. I don't have an easy answer to that. Misinformation is everywhere in every walk of life.
And about everything, I suppose. It's just we're hearing it. There's a lot of noise about menopause now.
Yeah, look at my phone. You should sit down and scroll through my phone and see what comes across.
Must be sent to you. Yeah.
Like it's 99% menopause. It's awful boring for someone who's not interested in it. So thankfully, I'm really interested in it, but it's a minefield. My job is to sort of know how to sift through the complete BS and how to look at stuff that's evidence-based. And I find it really overwhelming and I find it really challenging sometimes to figure out, God, that article is on the money or that article is really misleading. And if I find it difficult, how in God's name is someone with a passing interest or someone who has no scientific background supposed to filter through all of that stuff? It's really hard. I don't see the downside in talking about it. So if you have friends or the person in your shop or the bus driver or whatever who ends up chatting to you about menopause, great, what harm? But what you need to do then is follow that up with a chat with someone who is maybe more tuned in to the kind of scientific or evidence-based element of it. So if you're symptomatic, if you're somebody with a complex history in particular, and you're trying to work out, can I take HRT? Should I take HRT? Should I be on testosterone? What's the story with testosterone? Does everybody get osteoporosis if they don't go on HRT? All these questions that come up over and over again. You need to actually just sit down with your GP or someone in the complex clinic or whoever it happens to be. I love when a patient takes out a list of questions. Deep down, I know this person will leave and they will have the answers that they wanted coming in. And I might not even know the answer, but at least the questions they had in their head have been addressed. Write them down.
Yeah.
Like there must be nothing more annoying than going in and then you leave and you think 2 seconds later when you're in the corridor,
I didn't ask.
Crap, I forgot to ask, blah, blah, blah. Yeah.
And go to the trusted sources of information on HSE and go to the website that you have in the Rotunda and all the different places as well.
Should have said that. Yeah. So, and there are really good like online resources. So at the moment, the British Menopause Society, they're a really good resource. They have an excellent patient information page called the Women's Health Concern. We use a lot of their information leaflets. There's that. The HSE has really good information as well. And then Holles Street, the Rotunda Clinic, we all have our own resources online that you can have a look at. And then aside from that, I'm co-chair of the Menopause Society of Ireland at the moment. My co-chair is Dr. Claire Cromwell. So she's a brilliant specialist down in Cork. And we have a brilliant board made up of a few different interested people, but we are trying to develop, hopefully in the next few years, similar to the Women's Health Concern, an Irish-based patient resource area, I suppose, on our webpage. Yeah, that's the plan.
That's great. Things that women can do themselves. So if we talk about lifestyle and self-management and what we can take control of ourselves, things like diet, exercise, sleep, to be able to deal with menopause symptoms, what would your advice be in those areas?
Like, I think it's all intuitive. It's not earth-shattering for me to sit in front of somebody in the clinic and tell them, you know, you should reduce your alcohol and reduce your caffeine and look at sleep hygiene, you know, going to bed at the same time every night in a cool environment and switch off your phone. And you're like, patients nod away because by the time they come into us, they've done all of this. They know.
Yeah.
They know about exercise. They know about making healthy food choices and reducing triggers like alcohol and caffeine. So I'm aware that they know all of that. We often give it lip service because occasionally you stumble across something and they go, oh, I never actually joined the dots between, say, their caffeine intake and the fact that they're peeing 3 times at night, that kind of thing. Cognitive behavioural therapy, CBT, is the other thing that has really kind of taken off, particularly through the NHS and in the UK. So the new guidelines that were published over there recently, they're quite heavy on their focus on the benefits of cognitive behavioural therapy, or CBT, for mood and sleep and anxiety, and even for hot flushes and night sweats. One of the barriers with CBT is accessing it. Like, we're not exactly tripping over CBT experts, but the IACP, the Irish Association of Counselling and Psychotherapy, iacp.ie, is a good website. It's a directory where you can go and look up people who have accreditation or who have some kind of specialty in that area. For women who've come through a cancer diagnosis, there's ARC Cancer, ARC, arccancersupport.ie. And that's a good place to access counselling or CBT too, or through your GP.
Yeah. So if you say a lot of people are informed about the diet and the alcohol and exercise, then what are the biggest issues that people are coming to you and you're seeing in your clinics?
We're 2.5 days a week in the Rotunda. So I have to point out, like, the hypocrisy sitting there telling someone, you know, and cutting down the caffeine and whatever. And like, there's maybe a line of coffee cups in front of you on the desk and you feel like an awful hypocrite. You can't lifestyle your way out of everything. So that's where some of the wellness stuff annoys me. Sometimes if I say something like that, you can be accused of being this real pro, everything should be pharmaceutical. And I don't think that either. Where's the nuance? You know, we should be able to say, absolutely start with lifestyle, start with your diet, start with things like caffeine and alcohol and reducing smoking and all that stuff you kind of know you should and shouldn't be doing, and see what improves. And don't blame yourself. It's like with weight. There's a real culture of blame that, well, you know, if you're struggling with your weight, I mean, obviously it's because you're eating too much and you're not exercising. And that's nonsense.
The whole guilt thing is terrible.
It's completely stigmatizing. And also, we're kind of putting all the blame on the patient. But we know cholesterol is a good example. So, yeah, if you make certain lifestyle changes and you are more focused on what you're eating and you make healthy food choices and plant sterols and you exercise more, for most people, we will see an improvement in their cholesterol, which is great. But there are plenty of people who could live perfect diet, getting their 150 minutes of exercise a week, and their cholesterol will still be raised because your liver makes cholesterol, and a lot of that is genetics and aging. So they need a statin if their risk is high enough. So same idea, you can do everything you can with lifestyle, and you should, and your long-term health will benefit. But that does not mean that you'll be symptom-free. Yeah. Some women will. And for the women who aren't symptom-free, well, that's where we come in to have a more in-depth discussion about the next steps.
And what would the next steps be?
So that depends on your own leaning, your own attitude to medication. Not everybody wants to be on HRT, and your medical history. Not everyone is a candidate for HRT. And sometimes we think the risk probably outweighs the benefit. So that's case by case. So if we go back to women with hormone-dependent cancer, or typically, as I say, it's women with a history of breast cancer that we're seeing, we don't want to prescribe HRT. We don't really know what the risk of prescribing hormone therapy is after a breast cancer diagnosis. We don't know what that risk is. So we look at alternatives. And if we've gone through all the lifestyle changes and modifications, then we look at non-hormonal medications too.
Okay.
And that depends on what your symptoms are. Stating the obvious, no two women are the same. But for some women, they'll come in and for them, it's all hot flushes and night sweats. For other women, it's sleep. That's the big issue. For other women, it's mood. For some poor women, it's all of that, or vaginal symptoms, or libido, or sexual health and sex drive. And anyway, the list goes on. And what we'll do is we'll try and target the symptom bothering you the most. So if you come in saying, I'm getting lots of hot flushes, but they don't bother me, but I'm not sleeping.
Yeah.
Well, then I will treat your hot flushes, but we won't focus on that. Well, let's treat your sleep first, if that's what's bothering you.
Okay.
So that's where you need the discussion.
And then you're not afraid to prescribe whatever is needed then for that sleep.
I think people often come in thinking, if I mention sleep, what's going to happen is I'm going to be given a prescription for sleeping tablets, and I don't want to be on sleeping tablets.
Yeah, and then I'm going to get addicted.
Yeah, and they might, because sleeping tablets are addictive. And general practice has really changed in the last 10 years, and there's a shift away from sleeping tablets for obvious reasons. But we do have other options. Again, we go back to kind of lifestyle and basics and sleep hygiene and CBT. And then after that, we look at things like melatonin is really helpful. It's over the counter in most of North America. It's not over the counter in Ireland. It's on prescription, but it's not a sleeping tablet, nor is it a sedative. Won't knock you out.
Yeah.
It works by, it's kind of like dimming the lights in your brain, sort of signaling to your brain that it's nighttime and you should be asleep. And because it's not addictive and because it's not a sedative, now not everybody improves with it, but it's a really good place to start. Some antihistamines are slightly sedative, but not addictive, and they're helpful. Not a great long-term plan, but they're helpful. And we've other medications that have sedative properties too that we can use. So we go through a list and we work through a list. So yeah, there's lots you can do for sleep.
Yeah. And you know what? For anybody, when you have a lack of sleep, psychologically, the pressure and the stress levels really increase. And especially, you know, if you've got a family and you're working and all the rest of it, lack of sleep can cause so many difficulties for everybody, really.
I think your tolerance of
Yeah.
all of the other symptoms is probably down if you're not sleeping.
Yeah.
You know, I had 2 people in clinic today just coincidentally tell me I'm not sleeping great, but actually, do you know what? It's not bothering me because I'm not working anymore.
Yeah.
So there's definitely, I think there's women leaving the workforce because there's a knock-on effect of they're not sleeping. And so they're tired all of the times. They don't enjoy what they're doing. They're irritable and then it affects their cognition.
Yeah.
So there's definitely a link between poor quality sleep and brain fog, which is something we hear about so much. And targeting sleep is really important.
I know that we've discussed this before, but just explain brain fog again.
Okay.
Just for our listeners.
So brain fog isn't a medical term, but is a term that we hear several times a day from different patients. And they're often referring to different symptoms, as in it probably manifests differently in each person. From a medical point of view, we know that if we take estrogen out of the body, so as you either lose it naturally or because of medical intervention or something like that, your brain has to adapt to functioning without this hormone that it had. And we know estrogen's really, I won't say really important, although it is important. It has an effect on how your brain functions. Your brain can function without it, ultimately, but it has gone through so much of your life used to having it.
Right.
And it has an impact on different processes in your brain, how it utilizes energy, different things like that. Even your thermostat, one of the regulators of your thermostat is estrogen. That's why we get hot flushes and night sweats. And it regulates serotonin production, which is one of the reasons we see mood changes with menopause or postnatal depression or that kind of thing. So when you go through menopause, then your brain is faced with like this loss of a hormone that's been kind of dependent on, and then it has to adapt to losing it. And that process of adaptation is what brings on what people call brain fog. And if you look at the literature, the most common and specific symptoms that people will describe is verbal fluency. So a loss of being able to find the right word. And if I'm ever doing talks and there's a room full of women and you say that, beyond anything else I say, there's this kind of collective nodding of heads of like, oh my
I'm
God,
nodding
I know
now.
that. Yeah,
As you're
I know that. I know that feeling. So it's so universal. It's more common than hot flushes and night sweats. More women get the cognitive changes, but we all think of like, oh, menopause and she's there with the fan, and it's actually cognition. It's the most impactful. A lot of women will say, I can deal with the hot flushes. I cannot deal with my brain. What's wrong with my brain? And I think some of that in recent years as well is that we now occupy more demanding positions. We're juggling more. You're in the workplace and at home for a lot of women. More is expected of you. So verbal fluency is one, finding names, finding words. Really frustrating symptom, drives you up the wall. And then the other one is short-term memory. I can't remember what the hell did you tell me this morning? Or the, if I don't write it down, I won't remember it. And so like there's just notepads accumulating in your handbag and your phone. And you
completely get that. I write with a pencil. I've pencils, I've notebooks from every meeting I have. And I may never use them again, but at least it's like a security blanket for me now that I remember to think, what exactly did they say there? I know I have to do something. I knew there was a few actions from that meeting, but let me just have a quick look and check to make sure that I've thought of everything.
Yeah.
I shouldn't be saying that now because my colleagues would be listening to me.
That makes so much sense. Have you seen Noreen and her pencils and her notepads? But it's confidence.
Yeah, it is.
And like a number of women who'll say to me, it is confidence. And they walk into a meeting with anxiety thinking, I'm going to get found out now because I won't be able to find the word, or I'll forget the thing they told me yesterday that I was to talk about today, or whatever it might be.
Yeah.
And again, that drives women to be more introverted and to stay at home more and not want to interact as much. I mean, I'm bad with names at the best of times, and I live with this constant social anxiety that I will bump into someone and I really should know their name and I won't. And then the panic of not knowing it makes it so much worse. And then I sweat and I can't think of their name. It's just horrible. And so you almost want to avoid that situation. You know, do you ever have that nightmare of like you'll bump into someone and you'll have someone with you and you have to introduce them to each other?
But you see, the thing is, I have an excuse now because of menopause.
Just a shrug, menopause.
It's just a menopause thing.
And everybody will nod and smile. I know exactly what you're talking about. So the encouraging thing about brain fog and cognitive changes is that we know for the majority of women, if we leave you alone and do nothing and don't put you on HRT, even without hormone replacement, it is a symptom that improves over time. Doesn't make you feel better today, but I think knowing that it's not a slippery slope into dementia, which is what a lot of women are scared of.
So that's really good. So even if they can't, you can reassure them that this will get better with time.
Just can't give you a timeline, but it will get better with time. Yeah.
But there's no medication that can be given.
There is no medication for brain fog. No, there isn't. I mean, looking at sleep and exercise and those things definitely has a positive impact. So it's important to do that. But I find women who come in, and particularly in the complex clinic, because they're often women who just can't go on HRT, it's too high risk. And they will say, number one, I'm going to get dementia, because that's all I've heard about in the media is that if I don't go on HRT, I'm not protecting my brain. It's really important to dispel that completely and reassure them. And the same, I suppose, with bone health and heart health. They feel like I'm going to somehow be unhealthier almost if I don't go on HRT.
If they don't.
FOMO. Yeah. They get this proper, like, I'm going to miss out. Really important that we reassure them there's so much else you can do, and your bones and your heart and your brain, we can protect all of them equally well without HRT.
I'm just imagining the reassurance that people must get from talking to you, or maybe the nurse in the clinic or whatever, about all of this, that they're reassured that they're not going to get dementia and they're not going crazy. And if you stick with it, it'll be okay, as long as we try and help you with any of the other changes we can make along the way, even if you're not on HRT.
That's it.
So that's it. Yeah.
And it's a safety net, because I think it's having somewhere to discuss those anxieties and fears and not be dismissed and feel validated. I'm allowed. I know I had breast cancer and I'm really glad that I'm doing well and that my cancer is treated and I'm here where I am, and that's brilliant. And then I think sometimes they feel that they've no right to say, like, I know I'm really lucky. Most women with breast cancer do really well with their treatment. Yeah. And then they feel like it's very hard to then say, I'm really struggling.
It's nearly like they should be grateful for getting through the cancer. Basically, and they shouldn't be asking for anything else. Aren't you lucky to be here? And that's just so not fair. It's about quality of life.
There's like 40, 50 years ahead of them. And then they feel like, I think, whispering, but like, I'm really struggling in this area. Or I'm not struggling at all, but I'm worried that I'm going to get osteoporosis, whatever it might be, down the line. And I think just having somewhere to voice that, and like what we'll do with a lot of women if they're doing really well and we're not starting them on anything, we bring them back in a year just as a safety net of like, don't panic.
Have you started virtual clinics yet?
Well, yes and no. So in the Rotunda, we do a telemed clinic on a Monday. So that's run by my nurse, who's brilliant. It's not video links, but it's all on the phone.
Great.
Because, you know, it's not convenient for everyone to drag their backside into the Rotunda. So it's great being able to offer people a telephone clinic.
Yeah.
And then what we do is we sit down on a Tuesday as a team and go through the list of people that she's talked to on a Monday. And I'd love to think she says it to me and then I swoop in with like, and then we should do blah, 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 blah. But actually she doesn't need me at all. She's handled everything and made all the right decisions and I'm completely supernumerary to the situation. But she's telling me what prescription to do. But we have a really in-depth discussion about it just to be sure. Yeah. And that safety netting
for the whole governance. No, it's fantastic. It really is. So where do we go from here? Looking ahead, what are the next stages you want to bring? Because I'm sure that you've got plenty of other plans. I know that your clinic is 2.5 days a week now, and then we've got the 6 around the country, but I'm sure you've got big plans for where we go or where you'd like to go. I know it's not easy.
I think the two things that kind of stand out, one is, and we touched on this earlier, is about trying to reach women who are going through, particularly through cancer treatment earlier. And to try be part of that early conversation so they have that link with us, which they may never need, but at least it is there. And then we're not scrambling maybe when they're down the line and the symptoms are ingrained, and it's much easier to meet them early on.
Absolutely. In my head, I suppose I keep thinking it was just written into the pre-op information in all of the different centres, particularly for maybe breast cancer and stuff. But it's easier said than done. I know that.
And we can build the capacity for that. Yeah. Like I know we can. I think even if it is in that early discussion and offered to a patient and then they opt in or opt out. But if they say, actually, I was worried about that and I wouldn't mind talking to someone, well, then they can do a referral to see us. Yeah. And then the other area is the more marginalised parts of our society. So maybe women from the travelling community or women who are new to the country who don't speak English. Like there's a whole area, there's a whole cohort of women who have, again, been kind of left out of the conversation for lots of different reasons. We are struggling to reach them adequately. And I would love to see a way of developing some sort of outreach programme so that we can reach women who maybe find it hard to access services like we have in the Rotunda.
These are always the difficult groups to get to, you know, with all of the services really, aren't they? It's an ongoing thing really with everybody. Caoimhe, what I was thinking about was people who are every symptom, everything that happens to them at a certain age, think, oh, it's just the menopause. Oh, it's just the menopause. And they might be misdiagnosing themselves and just thinking, oh, I'll just get on with it. How do you differentiate between that and the menopause?
With enormous difficulty. I think it's really hard. My husband sent me one of these videos from like TikTok, or it was some comedian anyway, and she did a sketch about, she's sitting in traffic and someone cuts in front of her and she's yelling murder out the window and she's, oh, it's menopause, and everything is menopause. You drop the carton of milk, it's menopause. The kids are driving you up the wall, that's menopause. Everything is theoretically menopause. And the problem is it could be, so that's the issue.
Yeah.
What's even trickier is perimenopause. So these are women still having periods, but may have developed some new issues or new symptoms or mood change, or like, how in God's name do we ever tease out or untangle what's a hormonal symptom versus, well, what's life stressors that are also having an impact versus mood changes that are not hormonal mood changes, but depression and anxiety and, other things. So it's really hard. It takes a really detailed history, and we don't get it right all the time. Sometimes we look at doing blood work. I just need to be really careful because like blood work is one of those things that there's a lot of misinformation about. So most people do not need bloods to figure out where they are in terms of their hormone production. And so it's kind of simple. If you've stopped having periods and you're more than a year from your last period, you do not need bloods to tell you that you are post-menopausal.
Okay.
Which means your ovaries are not making estrogen anymore, particularly. Okay. We wouldn't expect you to go back to having periods.
Do you still stay on HRT?
If you're symptomatic.
HRT forever?
You can do.
But what if you're afraid to even try and give up HRT in case of what will happen?
But then you need really good support. So you need the safety net of a good healthcare professional who will hold your hand doing that and say, okay, this is how we're going to do it. This is the plan. And this is what's going to happen if you don't feel well. You just need support. That's all. And some women take it for life because they get benefit more than risk for the rest of their life. That's totally fine. Not everybody should take it for life. The longer you're on it, the more impact it has on breast cancer, although that impact is small. So it's duration related. But for some women, they do feel better on it for life. Well, then go for it. But figuring out when you stop it can be tricky and nuanced. And you just need that's where like it's all discussion. It's all about just talking about it and trying to help someone figure that out. But going back to your question about how do you figure it out? So we do bloods in women who are younger, under 45, and have stopped having periods just to confirm, okay, we know why you've stopped having periods. But if you're over 45, we assume it's because your ovaries have stopped functioning, which is fine. And we do blood work sometimes to rule out other things. So not everything is menopause. Yeah. I have been caught by this and felt really stupid before. So it's one of those, you make a mistake once, you never make it again type thing. So I'll always have my antenna out a little for things like thyroid function or anemia or iron deficiency or celiac disease or other things that can often mimic menopausal symptoms. Or sometimes like we get referred really strange things like women in their 70s who can absolutely still have menopausal symptoms, but that's not the kind of norm. It's not the usual thing, but it's possible. But say someone who, mid-70s who started having menopausal symptoms last year, that's a bit odd.
Yeah.
So again, we'd start to look at, well, hang on, have we missed something? Is there something else medically going on here? So we do bloods and other investigations there. So that's where that's useful. For younger women who are perimenopausal, still having periods, symptomatic, I haven't a rashers if it's hormones or something else, nor have they. We treat them. Do 3 or 4 months of HRT and figure out if you feel better. It's as simple as that.
Okay.
Yeah.
Yeah, as simple as that. And none of it sounds simple to me, I have to say. It sounds very complex.
But no, like it is straightforward. If you're younger and you're not sure, provided there's no reason you can't take HRT medically, then if you're happy to do a trial of 3 or 4 months, that will help you figure out.
Yeah.
You either feel better or you don't.
Yeah. So Caoimhe, from the 1st of June, is it women can get free HRT?
That's right.
And it's fantastic. So now we can get free contraception for a certain age group. And now we free HRT. So what are your thoughts on that?
I think it's brilliant. I mean, anything that is removing barriers to care or barriers to any sort of intervention that is effective or positive or going to make you feel better, then we'd embrace that. Nothing is perfect, but yeah, it's from the 1st of June. So almost all types of what we would consider to be hormone replacement therapy. So your patches and your gel and your spray and progestin capsules and Mirena coil, if you're using it for HRT, all that kind of thing are now free and covered by the government. And there was an agreement reached over the prescription dispensing fee. And I think you can find a list of pharmacies that have signed up to this scheme. There's a pharmacy finder on the HSE website.
Yeah, there is.
You do need to have a valid drugs payment scheme card, and you can apply for that through the HSE website too. So it's great. And then, as you say, the contraceptive scheme as well for women up to 35 will cover their contraceptive options. The only issue, and I'm going to not be negative about it, I think it's brilliant. How do you complain about something that is so positive? But going back to kind of what we were saying about women who maybe have had breast cancer or another medical condition who feel they can't take HRT, they still need treatment, and they're on medications, and they're often not covered, or they might not reach their drugs payment scheme limit, and so they end up paying for it. They're being left out a little. So it's just worth throwing that out there. And, you know, I don't know if the HSE find money stuck down the back of the couch. Maybe they will find a fund to include these women for their non-hormonal medications that are for their menopausal
particularly
symptoms.
if it's prescribed even if they started off with it being prescribed in the Complex Menopause Clinic, that at least that is free then if it comes from your clinic.
And it's very definitely then being used for menopausal symptoms specifically. Yeah, that's the only thing. However, you have to commend everyone who got it over the line. I think the Minister, Carol McNeill, has done a really good job at bringing it to fruition. So big strides in women's health in the last 5 years, all of it really positive.
Yeah, there really is. So to our listeners then, really what we want to say to them, even if you have had breast cancer, if you've got some other chronic illness, don't be afraid to go to your GP. There are complex menopause clinics there that can help you, and don't suffer in silence and just go and reach out for help. Isn't that really the message then?
Yeah, and even if it's just, you know, I'm not sure, am I bad enough in inverted commas to need to go on anything, but I have loads of questions. Like, I'd love those consultations. Ask for a referral. Come and see us and let us counsel you and walk through all of that and give whatever advice we can. And then we're linked in with you. And if things change and you feel worse and you do need medication, well, then, you know, we're there. Reach out. I think that's all you can do.
Well, thank you very much, Caoimhe. So that brings us to the end of today's episode. Thank you to Dr. Caoimhe Hartley for sharing her insights on such an important and often overlooked area of women's health. Complex menopause can be a very difficult journey, but with the right support, care and information, it can be managed. And we've heard that from Caoimhe. Whether you're experiencing symptoms yourself or supporting somebody else who is, remember that you're not alone and their help is available. So thank you for listening to HSE Talking Health and Wellbeing. If you enjoyed this episode, please share with friends, family and colleagues. You can find any of our previous episodes wherever you listen to your podcasts. If you'd like more information or would like to get in touch with us, please email us at healthandwellbeing.communications@hse.ie. Thank you for listening.